Welcome to HealthiHer, the podcast designed to inspire women to lead lives filled with health and happiness. I'm Dr. Amy Brenner, your host discussing nutrition, hormones, aesthetics, sexual health, and more. Join us each week as we dive into feeling better, looking better, and living better. Hey, podcast family. Welcome to another episode of HealthiHer. If you've had heavy bleeding but don't really know why, or maybe you've been told before you've had fibroids but don't want to have a hysterectomy, then this episode is for you. Today we have Denise Lyon, and we're going to talk about all things fibroids. So welcome,
Yes.
Denise.
Thank you, Dr. Brenner. I am so excited to be here with you and to discuss fibroids with your podcast listeners, because I just think that women need more options out there when talking about their fibroid treatment options.
Yeah. So before we get into talking about fibroids and heavy bleeding and all these options, could you just give people a little bit of your background and why you're one of the fibroid treatment experts?
Sure. Thank you. As you said, my name is Denise Lyon, and I am a market development specialist with a global women's healthcare company called HealthiHer. I've been with HealthiHer for about 9 years. Prior to HealthiHer, though, I worked in a OR as a surgical technologist, actually here in Cincinnati, Ohio. I was at the Good Samaritan Hospital. And my back specifically, told me I needed to make a change because standing next to an OR table for 10 to 12 hours wasn't feasible for much longer. And an opportunity came open with HealthiHer, and I thought it fit for me to be able to support and take my surgical knowledge and support women's health, because I think of myself I've always thought of myself as a women's health advocate, both a family diagnosis of endometrial cancer, my own struggles as a female with fertility and other things. And it just was a really good fit for me. So as I mentioned, I've been with it for about 9 years now. And specifically, I support currently the Acessa procedure, which is a option I know that you've recently started treating your fibroid patients with, if they're a candidate. And I just love being able to educate physicians and patients and operating room staff about the Acessa procedure, but more importantly, just making sure that women know that there are options out there for them that maybe they haven't heard about in the past.
Yeah. You know, I've been a gynecologist now for 24 years, and it's really exciting where we sit in 2024 now. There are actually a lot of options to treat heavy bleeding and treating fibroids versus when I was a resident, our choices were birth control pills, abdominal hysterectomy, vaginal hysterectomy. Occasionally we would do this roller ball ablation. And myomectomy. We would cut people open and cut out the fibroids. But today we're going to talk about so many other options for the treatment of heavy bleeding, and specifically heavy bleeding as it relates to fibroids. So.
Yeah. And I love that too. I love that for women's health. As a community, we're actually trying to get out there and make sure that physicians know that there are more options. Like you said, better is possible for women, and the Acessa procedure definitely is one of that. But we're talking about fibroids and bleeding, and I think that it's probably important, if you don't mind me asking you a few questions, Dr. Brenner.
Yeah, that'd be great.
What exactly is a fibroid?
Yeah.
When your patients come in?
So, fibroids are almost always a benign growth of the muscle of the uterus. So very rarely they can have some cancerous cells. I will say in my 24 years of being a gynecologist, I've only seen a cancer in a fibroid called a leiomyosarcoma only one time. And previously, I was in a large group with 10 other gynecologists, and I don't remember that being very common, although it has been reported. So almost always there are these benign growths in the uterus, and they can really wreak havoc for a lot of women. Some of the symptoms that they can cause are heavy bleeding. If they get big enough, they can cause pelvic pressure. So just overall a sensation of fullness in the pelvis. Depending on where they're located, that can also dictate what the symptoms somebody's having. So typically, if the fibroid is in the cavity of the uterus, or I explain to patients the space where a baby would grow.
Yeah.
Those tend to cause a lot of heavy bleeding. If they're on the front wall of the uterus and the bladders on the other side, they can interfere with urination or cause frequent urination. If they're on the back wall of the uterus, they can even cause like some back pain or push on the nerves of the pelvis or interfere with having bowel movements. Um, they can cause some discomfort with intercourse. Sometimes they can even interfere with fertility and cause pregnancy complications if they get large enough.
Yeah, when I first started learning about Acessa, because Hologic had only acquired this technology in 2020, I knew fibroids caused heavy bleeding because I've supported our other surgical portfolio, which I know that you're aware of and you offer here at your office. But I really wasn't aware of all the pressure symptoms and what we call, I guess, bulk symptoms, and how that really can impact a woman's life and quality of life. And I think a lot of the patients themselves don't even realize, maybe they think they're just gaining weight that's why their jeans are fitting tighter, but really it's this benign tumor. So you said that they grow in different locations, and you mentioned in the cavity and then on the outside. Is that the only places that the fibroids can grow? Or, as far as when we're talking about the Acessa treatment, I know that we say we can treat almost all of the fibroids. So where else can they grow?
Yeah. So, and where the fibroids are also makes a big difference of how we're going to treat them. So, like I said, they can be in the cavity of the uterus. They can be inside the muscle of the uterus, and half in the cavity, half in the muscle, in different proportions. And we grade them as physicians of how much is in the muscle of the uterus and how deep it is, and whether most of it's on the cavity or if some of it's on the outside. They can be in what's called a subserosal location, which is kind of on the outside of the uterus. They can be hanging off the uterus like by a little stalk. We call that a pedunculated
Okay.
fibroid. Very rarely they can be in the lower uterine segment or in the cervix, but that's a pretty unusual to find a fibroid in that spot, but they can be there.
So, in addition to being surprised maybe by the symptoms that the fibroids can actually create for them, how many women would you say are affected by fibroids in the United States?
Yeah, so it's really common. I would say over 70% of women have fibroids at some point in their life. Now, that doesn't mean that 70% of women are going to be bothered by fibroids, because sometimes they're just an incidental finding that maybe they're 1 centimeter or really small. And typically, we don't do something about that unless we're going in like an Acessa. What's great about it, we'll talk about that a little bit more, that we can treat those little guys before they become a problem. But I would say most women, 70+% of women do have fibroids. So it's really common.
Yeah. And I think that, tell me if I'm correct, that even women that are Black or African American women, they actually have a disproportional problem with fibroids where they are burdened. Is that true?
Yeah, absolutely right. So high percentage of fibroids in the African American population. The only way to really know you have fibroids, or if you're bleeding, pressure, or those symptoms that we just talked about, is you need to have an imaging procedure. I think a pelvic ultrasound is the best way to assess imaging, or to assess if somebody has fibroids before we do a procedure or talk about treatment options. In my practice, I like to do what's called a saline ultrasound or a sauna histogram. So first, the ultrasonographer puts a probe on the abdomen to see if there's any of those fibroids that are pedunculated or kind of hanging off the edge of the fibroid. And then she'll put a probe in the vagina to get a closer look at the uterus. And then I'll put a tiny little catheter inside the uterus and put some fluid in there, and it opens the walls of the uterus to see if there's a submucosal or a fibroid in the lining of the uterus. I know a lot of doctors like to do a hysteroscopy of putting a camera in the uterus to
Yep.
assess for that. And that's a different technique, certainly acceptable, but that's how we do it in my practice.
And that's one of the things that I really enjoy is the fact that you offer so many options, but that you really are trying to make sure that you're getting them a definitive diagnosis when they come in to see you. We mentioned the fact that back in the day, hysterectomy was probably a common. And do you know about what percentage of hysterectomies? I think there's like over 600,000 hysterectomies performed in the U.S. each year.
I think it's the most common procedure that a gynecologist does. So, and again, for the longest time, I know my mother experienced heavy bleeding and had to have an abdominal hysterectomy. So probably our mother's generation, you had heavy bleeding, you got a hysterectomy. So it's a really common procedure. I know a lot of doctors just, you have heavy bleeding, that's what we're going to do. But again, there's a lot of other options.
Yeah. And about 50% of those, I think, in the US are performed because of fibroids. And so, thinking about removing an organ in a female's body because of a benign tumor, I feel like there's got to be better ways. And that's why I'm happy that we're going to talk about Acessa.
Yes. So,
when a patient comes in, what other things are you working them up for as far as their symptoms of heavy bleeding?
Yeah, so I always also like to do some blood work. I like to do a CBC. I like to look at their iron level. I like to do a thyroid test. Because if somebody is significantly anemic, then, first of all, if they choose to have a hysterectomy, they might need to have a transfusion. That actually happened to me last week because somebody was significantly anemic and was just feeling horrible. So, and had a really low hemoglobin. And so she actually needed a pre-op blood transfusion. But even if somebody doesn't need a transfusion, if they're significantly anemic, then I would say, I think we really need to do something about this versus if somebody is not anemic, then I think that maybe the options are more, let's talk about how much this is interfering with your life. And then we can weigh the pros and cons of if treatment is necessary or if just expectant management could be considered.
Do you think that sometimes patients will come into you and they don't even realize that their periods, like they don't know that they're anemic, they don't realize that their periods are abnormal? Can you kind of give me an idea of what a normal period is compared to like an abnormal period, or how much bleeding is too much?
Absolutely. Because as women, we know we're not like showing other people like look at my pads, look at my tampons.
Is this how much you have?
Is this what you have? Like we don't really do that. And so
sometimes we don't even talk to our own mothers about it, especially like my mother's generation didn't talk about it. It's like, this is what you do, this is how you deal with it. And then that was the end of the conversation.
Right. I mean, I have 2 college age girls and same thing. Like they're not showing me like how much they're bleeding. Like, I will say, except one time we were on a college tour. She's like, Mom, I literally just bled and it's on my shoe now. So unless it gets to that point, like you're not really hearing about it.
And it's kind of taboo, right? Because if you do get blood on you, I mean, heaven help that you're a woman in a working environment and you get blood on your pants and you have to deal with it. It's taboo, it's embarrassing. So how much is too much?
Yeah. So again, in a research setting, we're quantifying it and doing pad counts, but really from a medical standpoint, we're not asking people to quantify it. So it's really if it's interfering with your life, if you're changing more pads or tampons that you should be, it's more of a subjective standpoint. I think you kind of have more data from like exactly quantifying it. But from my standpoint, from a clinical standpoint, we're just asking, are you soaking your pads and tampons more than every 3 or 4 hours? And I have some patients that say, oh my gosh, I have to change a super tampon like every hour. And that's not still, that is definitely not normal.
Right. But they're like, but it's what my mom did, or it's what my aunt does, or my sister does. And so for them, it's what they believe is normal, even though from a medical standpoint, it is not, right?
Yes. Do you have any specific data of a little bit more scientific?
So I did look it up in preparation for this discussion today, and they say the average amount that a woman should lose is in the course of her entire cycle. And again, a cycle being, hopefully every 28 days and lasting no more than 7 days. So that is normal. So if your periods are lasting more than 7, medically, from a standpoint, they consider that abnormal. And then if they're losing more than 1.5 shot glasses of menstrual fluid per cycle. So it's not per day. It's definitely not per hour, but more than, and so that's more than 1.5 ounces of fluid. And that's about 100 milliliters, I get. No, it's actually less than 100 milliliters. So it's actually not that much blood loss that you should be losing for medical normalcy.
Right.
But we know that women are, and they need more choices.
Yes.
Like you said, it affects your life.
It affects your life. So,
and if a woman can't, I hear the stories of patients where they don't leave the house that week of the month, because they're so worried about the idea of leaking, or they're wearing, 2 products. They're using tampons and pads, or in some severe cases, they're wearing adult diapers to handle their menstruation.
Yeah. Or you don't want to wear white clothes, or, I remember before I actually had an endometrial ablation, which is another product that Hologic makes, the NovaSure ablation. Again, not related to fibroids, but before I had that, I remember being at a swim meet, and I was standing at the edge of as a judge, and then after the first event, I had to wrap a towel around me, and my husband's like, did you get wet already? I'm like, no, I bled through my clothes. So
I also had an endometrial ablation for very similar. So, I was standing in an OR because that's what I do. And I looked down and my scrubs were covered in blood. And I said, okay, we can do something about this.
Yes. Or I would be at work and wearing my white coat and stand up, and one of my male partners had said to me, you have blood all over your coat. And then I just blamed it on a patient. There must have been blood. And that was so embarrassing.
Yeah. So let's break that taboo and let's make sure women are talking about it, right? That's one of the things I love about being able to do what I do every day, is that we can try to normalize some of this.
So yeah, let's shift the conversation and talk about some of the options for the treatment of fibroids.
Absolutely. So if a patient comes in and you've done your imaging and you're telling her that she has fibroids, how do you counsel her on what her options are?
Yeah. So certainly if they're not significantly anemic, and somebody's having heavy bleeding related to fibroids, there are a couple medications out there that somebody can take if they didn't want to have a surgical procedure for fibroids. I will be honest, it's not my favorite option, because how they work is essentially inducing a medical menopause. And I think that there's a lot of health benefits to having optimal hormones, and that's a conversation for another day. But I will use these medications for somebody, if somebody wants that as an option. But I've seemed to use them as a bridge. Look, I really want to have this X procedure, but I can't do it right now. I need to wait until the summer, or I just started in this new job, or maybe they do have severe anemia, but they don't want to get a blood transfusion. So we're going to slow down the bleeding, maybe have them take an iron supplement to build up their blood count. So I like to use it as a reserve, but it's certainly an option. If somebody's fibroids are located in the cavity of the uterus, my preference for that is to do a resection of that fibroid, and I use a device called the MyoSure. So I actually go up into their uterine cavity with a camera, and basically that device kind of chomps at that fibroid until it's completely removed and the cavity is normal.
Okay. So that's like a hysteroscopic myomectomy.
Yes.
And that's
so there's
not
no
invasive.
incisions on the abdomen. It's all done through the vagina and through the cervix. But if those fibroids are in the muscle of the uterus, up until recently, if somebody didn't want to have a hysterectomy or a myomectomy, we didn't have an option. Or a lot of times we would just leave those fibroids be. Um,
Watchful waiting, right?
yep.
That's kind of one of the terms I've heard used for it. Um, there's another procedure, and I don't think it's used very often. Maybe you can tell me why that you as a provider would use it or wouldn't use it, and that's uterine artery embolization. I know that that is considered like another minimally invasive option that's not a myomectomy or a hysterectomy. But why is that something that maybe a patient would or would not be a candidate for?
Yeah, so uterine artery embolization is actually a procedure that an interventional radiologist does rather than a gynecologist. It's done in the hospital, and my understanding is the doctor basically accesses the vessels in the groin and basically puts these something in the vessels that cuts off the blood flow to the uterus and then causes those fibroids in the uterus to basically disintegrate. Kind of the similar principle if you would tie a string around your pinky and you're cutting off the blood flow, and then over time the pinky would kind of die off. I think
Sounds kind of painful.
yeah, my experience has been it's been very painful. I haven't had a lot of patients over my career choose that option. Um, uh, but if somebody's just has a lot of medical comorbidities, and having any kind of anesthesia would be significantly risky to their health. Maybe they've had heart failure or a lot of medical problems where they just can't tolerate any kind of anesthesia. That might be a good option for them. Um, or if their fibroids are just so large of 15, 20 centimeters, that might be an option. But I think it's hard to find a radiology department that does that procedure.
Okay.
And my experience has been is that a lot of those patients do end up going on to hysterectomy because it doesn't seem to work as well, or there's just such significant discomfort or pain during that die-off period that patients are like, this is horrible, just take it out right now.
Yeah, I did a little research on that again in the prep for the show today. And I saw one woman post on a Facebook group that for her, natural childbirth was less painful than her UAE procedure. And that to me was kind of an eye opener because, but it makes sense, right? If you're cutting off the blood supply, you're cutting off its oxygen source, right? And so that sounds painful.
That sounds painful. Whenever I hear somebody say that they had natural child, just that word alone.
It brings images to our heads, doesn't it? So then how does Acessa, you decided to learn about Acessa and begin offering it to your patients. What brought you to that decision?
Yeah, I do think certainly I failed to mention hysterectomy is certainly an always an option
Right.
for heavy bleeding and heavy bleeding related to fibroids. Doing a myomectomy of cutting out the fibroids is also certainly an option. And those are still options for some patients. But what I like about Acessa is a lot of women actually don't like the idea of removing their uterus. Some do.
Mm-hmm.
But some women actually don't want to have a major surgery, and they don't want to have their uterus removed. And so Acessa is a great option. It's an outpatient procedure with minimal recovery that gives really good success rates for fibroids. And not just heavy bleeding related to fibroids, but the women who are experiencing those bulk symptoms of pelvic pressure, pressure on their bladder, pressure on their rectum, that kind of thing.
So you mentioned recovery. How long is the recovery for a myomectomy or a hysterectomy? Because we haven't really.
Yeah, depending on how we do the surgery, and they can be done open with an incision in the abdomen, or laparoscopic or robotic, which is going to lower the recovery. But even still, it's a big surgery. So I typically tell people, about 6 weeks, but anywhere from 4 to 8 weeks until they're feeling back to normal.
Okay. And so that's where having another option really does fit in. And that's why I'm glad that we get to talk about the Acessa procedure today. Just from like a high level overview of Acessa, do you want to tell them how you do it?
Yeah, so I tell my patients they show up first thing in the morning, or if their case is in the morning, but they'll show up nothing to eat after midnight. You'll get to the hospital, they'll start an IV, they'll put these boots on your legs to just help with circulation while somebody's asleep. And then you actually get put to sleep by the anesthetist. And then we just make two little incisions in the abdomen, typically one in the belly button and one like right where the side where the top of the uterus is. And we put two uh, probes or trocars into the abdomen so we can put our instruments in there. And typically a camera in the belly button and then an ultrasound in the other port. We're actually doing laparoscopic imaging so that ultrasound image is right up against the uterus. And then we basically just make a nick in the skin and put the Acessa device, which is a probe, and then the probe goes into the fibroids, and then these arrays open up, and that's what actually destroys the fibroid. So it's using radio frequency energy to destroy the fibroid and cut off its blood supply.
Yeah, so a little different than UAE in the fact that it's not cutting off the oxygen to it, but it's actually right there while they're asleep. We're killing the tissue of that fibroid.
Yeah, so you're the actually the Acessa expert. You're going to all the Acessa cases of all the doctors in the area. Can you talk about the mechanism of action but why is it different than UAE?
Yeah, so to use fancy science terms, we do coagulative necrosis versus ischemic necrosis. So ischemic is that cutting off the blood supply so that it dies over time. Coagulative necrosis is using heat or heat application to the cells, causing cell death at the time that heat is applied. And we do it using, as you mentioned, the radio frequency energy. That's a very safe, well-studied, predictable type of energy that is used in many different applications in surgery. And we just happen to use it, as you said, through the device that has these little 7 needles that come out of it and heat up just the fibroid tissue. And so when you're performing it, you're very specific to keep that instrument and the heat that it produces within just that benign tumor. And so then it leaves all of the rest of the uterine tissue healthy and it doesn't get in the way. So it doesn't block any blood flow to any muscle of the uterus or the lining of the uterus. So all of that stays healthy and that you're just very specifically treating and more importantly, killing that fibroid so that it can't continue to grow. And it will actually get reabsorbed by the body over time and compressed. And so it will shrink.
So it's the same energy that is used in a Novish or ablation that you and I have. It's the same radio frequency energy.
Yeah, this one's monopolar versus bipolar, but very, very similar, very safe. And like I mentioned, the importance to you guys as surgeons is that it's reproducible and predictable, that it's not going to do anything and travel where you don't expect it to travel, that type of thing when you're dealing with the human body. So, so and as you mentioned kind of at the beginning, that with Acessa, we can treat even small fibroids. About 1 centimeter is our smallest ablation. That's what we call it, is an ablation of the fibroid. And so we can treat even a 1 centimeter fibroid to keep it from becoming a 5 centimeter or, as you mentioned, 15 centimeter fibroids.
So one of the things I've noticed in my cases is certainly all of my patients have had an ultrasound where we've done in my office. So I have a little bit of a map going into it of what to expect. But when we've done our cases together, we've actually found more fibroids that my ultrasound in the office didn't detect. Can you speak to that?
So as you mentioned, during the procedure, you're actually going to have an ultrasound that's laying on the organ itself versus a transvaginal or pelvic ultrasound that you perform in the office where you're going through multiple layers of tissue. And so just being on the organ itself, you're getting a better ultrasonic image. And we know that we can find about 2 times more fibroids than what your transvaginal ultrasounds will find. And even if you were to do an MRI, which I know that you probably don't do for all your patients, but sometimes you might find that's a needed workup. we still find about 1.5 times more fibroids than even an MRI does, which is considered a higher level of imaging. So yeah, we definitely find more.
Obviously, Hologic, the makers of Acessa, have done or have done studies on this. Can you talk about the data behind the Acessa procedure of what physicians can tell their patients? Because I know actually a lot of physicians listen to this podcast as well. So, and patients, but from a clinical side of what the research says of what patients can expect as far as success rate of this procedure?
Yeah, so that's a great question. Thank you for asking. As far as the success rate goes, we have about a 94% of patients would recommend it to a friend. And we have about an 82% reduction in bleeding. And I know we talked a little bit about what normal versus abnormal or heavy menstrual bleeding is. For our patients in the original study that Acessa was able to get its FDA approval from, those patients were really bleeding. They were having about 500 milliliters of blood loss per cycle, which is a lot. These are the patients that we were talking about that are using multiple products, not leaving their house. And we were able to reduce that by over 100 milliliters blood loss. So over 3.5 ounces, or about 3.5 ounces of blood loss per cycle is reduced. So if you can imagine, if a normal period is supposed to be about 1.5 shot glasses, we are reducing these patients' bleeding by about 3.5 shot glasses. So that's a significant reduction. And also because of the fact that we do that coagulative necrosis, one of the other differences between us and UAE is the fact that it also softens that tissue. And so it's breaking down those cells and thereby breaking down the proteins of the fibroid tissue itself. So fibroids are kind of, as you know, very dense. You're actually touching them and cutting them out, but they're very dense.
Oh yeah, sometimes they can feel like a golf ball.
Yeah,
like that hard.
And so then we are denaturing that protein and then making it feel more like a marshmallow. And so the tissue stays behind. We're not removing it or cutting it out, but it is going to be much softer. And so that's going to make that bulk symptoms and that pressure be alleviated right away. So our patients are telling us in the studies when they wake up that sometimes their urinary urgency that they were feeling or frequency of having to go and empty their bladder constantly is gone just from waking up. And even though we don't see the reduction of the fibroid yet, and we do know, again, you asked for the data, so we do know on average the fibroids will shrink about 45% by volume. Now, that's kind of tricky to understand because volume is not something that we often think about. We tend to think about 2D dimensions and going from a 2 centimeter fibroid, well, cutting it by 45% or almost half would take it to a 1 centimeter fibroid. But that's not how it works, is it?
No. That's the part I struggle of explaining patients when we're measuring it. We say, oh, your fibroid's 8 centimeters. It's not going to be 4 centimeters. So like, do you remember how to calculate volume that you learned in 5th grade? Like,
yeah, 4/3 pi r cubed, but nobody needs to know
impressive.
that. But I think there was a demonstration by one of the other physicians that I've worked with that made it make sense to me. Since we don't conceptually really understand volume and how much 45% really is shrinking the fibroid, you have to think about an orange. If you were to take an orange and peel it off, and then ball that orange peel up in your hand, the orange peel itself is going to be about the same size as the orange fruit in your other hand. So that's how much the volume of just the outer covering of that fibroid is. And so if we're reducing you by about 45%, we might only take an 8 centimeter fibroid or let's say a 7 centimeter fibroid, because that's what we studied. It might only go down to maybe 5. And so you might not think, well, that's enough, but we've also softened it. So we've taken that pressure that it was creating as well. And more importantly, we're going to keep it from growing anymore.
Mm-hmm. But the point is really about the clinical endpoint, and the clinical endpoint you already mentioned.
Yeah. And so we're also going to reduce the overall uterine volume by about 25%. So the uterus itself, when you have those fibroids shrink in it, then your uterus actually goes down. And so maybe you don't look like you're 2 months pregnant or 4 months pregnant or whatever anymore. Because I know that some patients with fibroids suffer from that, right? Where they're told that they look like they're pregnant. So by us being able to reduce it by 25%, that will help you to get that figure back.
Yeah. Did you already mention the recovery of just being a handful of days. That's been my experience too. A lot of patients are like, well, you gave me this Percocet or this narcotic to take. I took it that night just because, but otherwise they didn't really need it. And that's what's been just so great about this procedure is the recovery is just remarkable compared to a hysterectomy.
Yeah, our average, we typically say 3 to 5 or 4 to 5 days is all that it takes to be back to normal activities. And so if you're talking about a busy mom or somebody who's working and you just don't have the ability to take it, because you said like 4 to 8 weeks for hysterectomy to feel normal again. So our patients are going to start to have that recovery much faster, be able to get back to their life and much sooner, which I think is why it's such a great option that has come out. And I'm really happy to be around supporting it.
Yeah. What about the negatives or what about the cons of this procedure compared to the alternatives?
Well, it's not a definitive procedure. We're not removing your uterus, so you could grow more fibroids again. We did have in our study about an 11% reintervention rate, and that means going back in and doing something else. Most of the time for our study, it was hysterectomy. But what we found is when those patients had their uterus evaluated in the pathology department after the surgeon had taken it out, that they found another disease state within the uterus. So about half of that 11% had something called adenomyosis. You probably can tell better what adenomyosis is than I can.
So most people have heard of endometriosis, and what that is where the lining of the uterus gets outside of the uterus, where it could be on the bowel, it could be on the ovaries, it could be just on the wall of the pelvis or the abdomen. Adenomyosis is similar, but it grows into the muscle of the uterus, and symptoms can be very similar to fibroids of pelvic pressure, heaviness, heavy bleeding. We can see some suggestions of it on ultrasound or MRI, but the only way to definitively diagnose an adenomyosis is to actually have a hysterectomy and have them look at it underneath the microscope.
Yeah, so I that's why I understand that those patients, about half of those patients went on to have a hysterectomy. But our study shows that it's a very durable procedure, meaning that the effects of it continue to last. Our study looked at it in 1 year and then again in 3-year increments and found that the patients remain satisfied 3 years out as much as they were at 1 year, because the body's going to continue to shrink down that tissue as the myometrium constricts around it, because that's a muscle and muscles like to constrict. They continue to shrink. So.
Yeah. I think in your instructions for use right now, it's approved for fibroids up to 10 centimeters. Hopefully one day we'll be able to do it on fibroids that are larger, because I had a patient that her insurance declined it because her fibroid was larger. So maybe that'll be something that will change in the future.
Yeah, as you mentioned right now in our labeling, we originally studied up to 7 centimeters. However, a couple of those patients, by the time they actually got onto the operating table, they had started off with something in their imaging, that their transvaginal ultrasounds or whatever, that said their fibroids were around 7. And so they were included in our study. And then by the time they got there, they were about 9.5, so almost 10. So that's why insurance will cover it up to 10, because that's what's in our labeling.
Correct.
So we'll have to see if anything changes. But for right now, up to 10 centimeters.
Yeah. How long has this been around? Because my suspicion is that most of you who are listening or watching may not have heard about the Acessa treatment for fibroids. So can you touch on that?
Yeah, which is kind of both not surprising and a little surprising, because the Acessa procedure was actually cleared by the FDA in 2014. So it's been out for 10 years. There's been a couple changes, though, to the technology over the years, and HealthiHer acquired it after the most recent technological advancement, which includes the ability for you to see where those instruments are in an electromagnetic field. So that's one of the other features of the Acessa procedure, is that not only are you using that image of the ultrasound, but we also place a magnet under the patient that creates this electromagnetic field that allows those two instruments, the ultrasound and the handpiece, to be able to know where they are in relation to each other. And that makes it easier for you as a surgeon to be able to get to those fibroids quickly and efficiently. And so once that technology was added to the Acessa procedure, Hologic was very interested in it and acquired it in 2020. And that's why it has started to kind of grow, and it's more in this area because it was just kind of geographically in certain areas. If you live in Chicago or Atlanta, perhaps you were aware of it sooner. But like Cincinnati here, for instance, it's been just since 2020 that doctors have really had it as an option to pick up and put in their fibroid toolkit, if you will.
I know I had gone to an all-day training. It was probably back in 2014, and was really excited about it back then and was ready to offer it to my patients, but it wasn't covered by insurance.
Yeah.
And so therefore, it was really hard to talk about because tens of thousands of dollars of having a surgical procedure that's not covered. So I think that's been some of the holdup too.
And that was something that we're very excited that Hologic was able to work with the commercial payers that are out there, the insurance companies, and say this should be a standard of care for fibroid treatment. ACOG says that it is, AAGL says it is, and those are, the societies that kind of help you and direct the practice of gynecology. And so we were able to work with those payers, and now we have 99% of lives covered. It's covered by Medicaid, Medicare, it's covered by all your major insurers. And so that has really made it a lot more easy, like you said, for providers like yourself to offer it to their patients if they know insurance will also cover it.
Yeah. It's just a really exciting time to be in women's health and gynecology. Like, it's just rapidly changing. And now we just have so many options and can sit down and talk to people about what's best for their heavy bleeding or fibroids. So
yeah, because I know that women can wait once they get that original fibroid diagnosis and they're kind of told what their traditional options have been. We find that women would wait 3.5 years before they would actively do something about their fibroids. And, that's 3.5 years of those heavy bleedings or those urgencies or back pain or just putting up with it because I'm a woman and this is what I go through. And so I think having another option out there that you can provide for them, and that's what's great for you, is that you learn about all of the options and you keep up to date on the things that are around the turn, if you will, and you make sure that you're learning them and staying up to date and offering them to your patients. So thank you.
Yeah. And that's been my experience as well, is sometimes patients will come in with a prior ultrasound report and they didn't like the options that they were given. And so they do some, what I think patients would say is natural or holistic alternatives, which I am a huge fan of those kinds of things in my practice. But unfortunately, I haven't seen them be successful for the treatment of fibroids, of shrinking fibroids or causing significant reduction in size or volume or symptoms. And then we do a repeat ultrasound, and sure enough, those fibroids are a lot larger. So
when you're working up your patients for Acessa, is there any need for them to have, follow up, or how are you counseling them on what it looks like for them post-operatively?
Yeah, I know in the training material is to repeat ultrasounds periodically to do that. Ultrasounds can be an extra expense for patients. So if somebody is not satisfied with the results, I think certainly an ultrasound is indicated. Or if somebody has the procedure, has great results, and then in the future may have symptoms that sound similar to what they experienced before, I think I would repeat the ultrasound. But otherwise, if somebody's, in my experience, really happy with their reduction in bleeding and reduction in their bulk symptoms, I haven't been doing an ultrasound just to see.
Yeah,
so.
Because the symptoms really is what brought them in, right? And so if the symptoms are still being taken care of, then no need to continue.
Yeah.
Can't think if there's anything
else.
Yeah,
I think we pretty much covered fibroids and heavy bleeding and related to fibroids. Thank you so much for joining me on the podcast. And hopefully you found this helpful. We'd love to talk to you if you experience symptoms of heavy bleeding or have been told you're having fibroids. Thanks for listening to HealthiHer. If you enjoyed today's episode, please leave us a quick 5-star review on your podcast platform. Your feedback means the world to us and helps others discover our show. Do you have questions or want to discuss a particular topic? You can reach us by emailing ask@dramybrenner.com or calling 513-204-8403 and leaving a voicemail. We might feature your question or comment in an upcoming episode, so don't miss out on the chance to be a part of the conversation. And don't forget to subscribe so you don't miss any of our upcoming episodes. We appreciate your support and can't wait to have you back with us next time. Take care, and remember, your HealthiHer journey begins with you. This podcast is for general information only and does not constitute medical advice, the practice of medicine, nursing, or other healthcare services. No patient-physician relationship is formed. The information in the podcast and any references, material, or links are at the sole discretion of the listener and not meant to be a substitute for professional medical advice, diagnosis, or treatment. Listeners should not delay or disregard obtaining medical advice for any medical diagnosis or issues that they may have, and should seek medical care or advice from their healthcare provider for any such conditions. Thank you to our guest, Denise Lyon from HealthiHer, the manufacturer of the Acessa ProView system. Rare but serious risks of the Acessa procedure include, but are not limited to, infection, injury to adjacent structures, blood loss, and complications related to laparoscopy and/or general anesthesia. Clinical data discussed in today's episode is available in the Acessa instructions for use. Per the IFU, use of the Acessa procedure to treat fibroids greater than 7 centimeters is off-label and not recommended by HealthiHer.